everybody? Reed here. How's it going? Today, we're going to have a very interesting conversation. It's going to be about Abilify Maintainer, long-acting injection. First, hey, Shariah, how you doing? Did you want me to put you on the screen or you just want to talk there? Hey, Shariah, how you doing? Can you hear me? Oh, I'm sorry. Can you hear me?
Yeah, I'm here.
How you doing? Okay, I have you on audio. Okay.
Okay.
All right. Um, so I'm making some coffee. Let me get my some tea. Let me get my tea first.
Okay.
Okay. Now it's Shariah, correct?
Yeah, it's Shreya.
Shariah. Okay. Gotta get the glasses on. How are you doing?
I'm good. How are you?
Hey, hey. While you're here, it'd be interesting to get your input on some of the lectures, or if I need to change anything. Any input? Uh,
No, I've watched your lectures, even like the ones you do on YouTube, and it's it is really informative, and I like that it's on YouTube, so I can just like go back and watch them like when I need to. So yeah, I like the format.
oh, that's great. Okay.
Yeah.
Nice.
Yeah.
I'm glad it's helpful. And believe me,
Yeah.
going through this stuff, man, I mean, it refreshes me up on everything. I mean,
hmm
it seems like everything is accessible now. Because you
Yeah.
basically study every day, right?
Yeah. Yeah. Even like things you discuss in the rounds, like when I'm doing my practice questions, like it kind of comes up, like how we have to do the tryout before we can do like the shot for
Hmm.
like the Haldol shot. You have to do the oral, so that was kind of like actually came up in a question. I was like, oh, I know this. We hear it every day, so
Mm.
yeah, things like that do come up too.
The benefit about my rotation is you see a lot of people,
Mhm.
and then you get the chance to see the pattern, right?
Yeah.
And I think that's the majority of it.
Yeah.
The patterns, everything else makes sense, right?
Yeah, especially because like the inpatient stuff is like you don't see it as much, like compared to like outpatient. Like you might see like depression and stuff you might see more regularly even in primary care. So like, but the inpatient, like the disorders, you it's like a good way to see it all.
Mm. Great. I got an idea for you. I'm so glad you're here. I get a chance to test out my ideas.
Okay.
Um, I've been doing this for like 6 years.
hmm
Like, and this is 7 days a week.
Yeah.
And all of my all of this is recorded on Zoom.
hmm
So my producing team is going to basically de-identify everything, make it
I
HIPAA
would make
compliant,
it like lectures.
and then basically do for a whole 30 days,
Oh, okay.
right? And
hmm
so we can run it as a simulation. I
Yeah, like the
you know, stream
cases.
it as if it's real, right?
Oh, okay.
So think about this. So sorry, chocolate
You're okay.
good. Chocolate good. Um, so I wanted to build a type of rotation that you can take from home and pay only $500.
Okay.
So imagine me streaming like this in real life. Okay, so I'm streaming
hmm
like this. And so let's say you're my assistant, right?
hmm
Now, let's say we're going to start the class like in 20 minutes,
Okay.
right? So all the people are going to be logging into the platform, right?
hmm
Logging in like they're doing right now, like you logging here. And then I'm going to start basically I'm going to start this, you know, and then whatever here, that's going to be playing, right?
hmm
But it's going to be streaming, right? So the rounds are going to be streamed here,
Oh.
while you and I are in real life, right?
hmm
And then after the rounds, then I can see patients online, or I can ask questions right there for the students.
Yeah.
What do you think? You see what I'm saying? So just like if you're my assistant, and then if you want to sign up for my rotation in psychiatry, it's just $500, right? So you
Yeah.
sign up, and basically you get the link, and you appear like on the stage, like you, okay?
Hmm.
Um, on the stage, like I didn't know if you wanted me to show you. Sorry. I'm sorry. I didn't know you wanted me to show you. Sorry about that. I'm new at this, okay? Um, but you can have more people who come in and watch just like you, but then they can just watch the stream of the rounds. Ooh, hold on. Ooh, hold on a second. Okay, I'm sorry. Repeat that again.
I said, yeah, it's really good, especially if there's kind of like it's if it's streamed and then you could watch the recording later. So like watching the recording I think is really helpful because you can like kind of go back, take
Yeah,
notes, or if you miss something. So it's like nice to have that library, like catalog.
yeah. But see, okay, so but my rounds, so my program is going to be in real life streaming.
Yeah.
So I would be here around my place, just available, right? And when it's time for school to start, they'll come in, I'll start the simulation. They'll go through the stuff for time. If they had any questions, they can just hit me up with any questions.
Okay. Would there be like a video library, like how you have your other lectures to go back to watch it? Like you can watch the
Well,
stream.
see, we're going to identify each day of rounds,
Mm-hmm.
and then attach metadata to the subject so it links to my YouTube videos,
Oh, okay. Yeah. That makes
right?
sense because
So
as
when
long
we
as
talk,
there's like something to go back to, that would help. Because
Mhm.
like the discussion in person does help a lot, like having the rounds and like watching and listening, like that's all good. And then because I know some people like it's kind of like after the fact, like, oh, let me go back
see,
to review.
see, the thing is that when they see me rounding, it's going to be streaming.
Hmm.
So it's going to appear to be in real life. I mean, in real time.
Yeah.
Or they can stop it
Hmm.
and click on the link
Yeah.
and get the video of me explaining,
Yeah.
and then restart the rounds.
Hmm.
Right? And then afterwards, the simulation, they just come back to this main group,
Hmm.
and we finish talking from there like that. I
Yeah.
would think that would be a cost-effective, very good way to get students in the program.
Yeah, especially because it is like you said, like pattern recognition. So it's like seeing the cases, but then also like getting into the details of like what differentiates kind of like the small details. Like that's how you can like start to learn.
Hmm. You think it's a good idea?
Yeah, I think so.
I think it's revolutionary.
Yeah, it
Because
is.
look how many medical students. I mean, look how medical students used to take a rotate needs to take a rotation in psychiatry, and you can do this from home for $500.
Hmm. Yeah.
Now, how did you? Now, like, what school are you from again?
I'm from Xavier.
And where is that at?
It's in Aruba, actually.
Okay, so you have to fly all the way over here to take this rotation.
No, so like after we do our basic science, like on the island, we do our rotations in the States. And so like if we're in New York or Chicago, like wherever we get placed, we go.
But you have to bear the expense of doing all the rotations.
Well, we pay tuition and then our school places us. So we don't pay directly, I guess. The school arranges it.
And they pay for your housing and stuff like that.
No, we pay for that.
So, but you still have to pay for yourself, right?
Yeah, yeah, we do have to pay. We just don't pay the hospital or anything directly. Like we pay the school and the school pays.
So I'm saying, but to be able to take a psychiatry rotation at home for just $500 is really inexpensive, right?
Oh
As
yeah,
opposed
that
to
is very cost effective.
and how much would it cost? Does cost on average now? Let's say if you had to come to Chicago, get a place to stay, and then do it for a month.
Yeah, I mean like rent would be like maybe like I don't know, 1 to 2 thousand, right? Like it'd be
Yeah.
expensive, plus cost of living,
And
even
then
groceries,
travel.
yeah, travel. So I feel like at least a couple thousand, like three
So,
ish,
but
maybe.
I think to offer this type of rotation, I think everybody was signed up because just for $500, right?
Yeah, it is really convenient. And like, and yeah, it is like a lot easier to do it like this.
Yeah, it'd be interesting. Well, thank you so
Yeah.
much.
Yeah, no problem.
Thanks for your input.
Yeah, of course.
So let's see. Today, um, this discussion is on Abilify Maintainer. Let me see here. Let me go through. Let me just first, Abilify is a atypical antipsychotic. So let me have an AI explain and see the mechanism of Abilify. It has a unique, like most of the antipsychotics, they block the dopamine receptors, but this does something else differently. You know, so let me say, Abilify, aripiprazole, is an atypical antipsychotic known as a dopamine serotonin system stabilizer. So here we're introducing the concept of both dopamine and serotonin. Remember, with the typical antipsychotics, they only bound like D2 strongly or D1 and things like that, but they didn't bind in other receptors like norepinephrine and serotonins. So the typical antipsychotics are used very effectively for psychoticism, but they are not really effectively used for mood disorders. But the atypical antipsychotics, because they target serotonin and norepinephrine and other receptors, they're also used as mood stabilizers also. So here's the dopamine from the antipsychotic component and the mood stabilizing component, because it also targets serotonin. Its unique mechanisms, that's what I wanted to point out, involves balancing dopamine and serotonin levels in the brain by acting as a partial agonist at certain receptors. Remember, the antipsychotics are supposed to block the dopamine receptors, and now they're saying it serves as a partial agonist at certain receptors, right? This adaptive or stabilizing effect is distinct from traditional antipsychotics that simply block dopamine receptors. Yeah. Um, so so you can see that these atypical ones, they're really important for stabilizing mood. You know, so I use them often when I can't figure out what the diagnosis. I don't want to say it like that. If I'm unsure what the diagnosis is, if it's a mood disorder, instead of putting them on an antidepressant, I'll go ahead and put them on something like Abilify, because the antidepressant, there's some evidence. There's we used to believe that antidepressants precipitated manic episodes, but I think there is some evidence that's coming that's questioning that. So I don't want to say that antidepressants precipitate manic episode, but that was the traditional understanding. So if I'm not sure if the person is really bipolar, but just presenting in the depressed phase of the bipolar disorder, then I'll just use Abilify because I know it can help with the mood stabilizing effects there. The dopamine system stabilization. Abilify's most significant action is its function as a partial agonist at the D2 receptor, the primary target for antipsychotics. Remember, this D2 receptor is very important. That's the target of those typical antipsychotics like Haldol, Prolixin, and Thorazine, and it's a potent blocker. So it gets into the receptor sites and it blocks the dopamine molecules from getting access to the receptor, so you can't trigger the receptor. And Abilify is activating. The Abilify is activating the receptor, right? The primary target, okay. This contrasts with older antipsychotics, which act as full D2 receptor agonists or blockades. Yeah, it seems like I'm right ahead of the AI.
Yeah. You're explaining it before they do.
Yeah. In areas with increased dopamine activities, okay, in areas with low dopamine activities. This is interesting. Okay, for conditions like schizophrenia that involve excessive dopamine in certain areas of the brain, Abilify act as a functional antagonist meaning blocks it. It competes with natural dopamine for the D2 receptors, but because it only partially activates them, it effectively lowers the overall dopamine signaling. Wow, you got it?
Yeah,
So,
that makes sense.
so Abilify competes with dopamine for the
Mhm.
dopamine receptor. And when it does, it just activates it just a little bit,
Yeah.
but it prevents the dopamine from binding, and the dopamine will activate it a whole lot more,
Mhm.
right?
Yeah.
Um, this is very interesting. When these people who think through this stuff have to be amazing people. Can you imagine?
Yeah, like how it, because it works for, I know, because like the atypical work for both like positive and negative symptoms,
Hmm.
right? So it's like, so this is like in the positive, like the
Well,
mesolimbic pathway, right?
yeah, see, remember, I did a lecture on a podcast on the negative symptoms, and I went through the literature, and
Mhm.
basically nothing really works.
Yeah.
It's just time. And then they were saying that maybe atypical antipsychotics like Seroquel at low doses and things like that, but they're saying nothing really works.
Hmm.
So with these, we focus on positive symptoms and just hope that the negative symptoms improves.
Yeah.
But
But
because
then,
it causes a functional blockade at the D2 receptors, it'll still decrease the hyperactivity in the mesocortical pathway.
hmm,
It only gets stimulated 1% as opposed to 100%.
yeah.
Okay. This helps reduce positive symptoms such as hallucinations and delusions. Right. In areas of low dopamine activity, in other brain regions where dopamine levels may be too low, hypodopaminergic, Abilify partial agonist activities provides a mild activating boost to dopamine signaling. It is believed to improve negative. Oh, that's the mechanism for negative symptoms, like flat affect, motivation, and
Hmm.
potentially cognitive function. Oh, okay. So it's the. I'm just now understanding that. So it's the. So apparently, in this schizophrenic state, you have areas of dopamine hypoactivities intermixed with areas of dopamine hyperactivity. So the Abilify will increase the. It's a malagonist, and so it will still at least increase the production of dopamine in those hypodopamine areas a little. And I guess that's.
Yeah.
Like I
Like
said, that's
stimulating the receptors.
this is great. Okay, serotonin, and I think it only gets better. It only gets better when you think about the serotonin receptor. I'm sort of like getting excited to see and hear about the serotonin, what it does with serotonin. Um, in addition to effects on dopamine, Abilify also modifies serotonin activities. 5-1-HT receptors and the 5-1-HT2A receptors, right? Abilify acts as a partial agonist at these receptors. This action is thought to contribute to mood stabilizing effects, especially when used to augment antidepressants. Okay. At the 5H2 receptors. Okay, now remember the um, remember the SSRIs, they're called selective serotonin reuptake inhibitors. They
Yeah.
work by turning off the serotonin reuptake pump on the presynaptic neuron, right? So,
Yeah.
so
So there's more like serotonin in the cleft to keep activating.
exactly. So that plume of serotonin in the synaptic cleft builds up, and then now you get more binding of serotonin to the serotonergic receptors. And
Mhm.
that gets the signal from the presynaptic cell to the postsynaptic cell, right?
Yeah.
Great. Now look at how they're proposed. Now that's the mechanism of all SSRIs.
Hmm.
Let's look at now they're describing the mechanism of an atypical antipsychotic that also binds the serotonin receptor. But look,
Yeah.
it actually binds the serotonin receptor and causes the postsynaptic cell to produce more serotonin, even though the synaptic cleft may be deplete of serotonin.
Yeah, so it acts like
You
serotonin.
got my saying? So
Yeah.
if it's depleted serotonin, then you want to go ahead first, turn the pump off, please. Just turn the pump off. Turn the reuptake pump off. Stop pulling the stuff back in. SSRI, right? And then so you put them on the SSRI, and then the starting dose 2 weeks later. Oh, I'm feeling better, but I have to increase it. A month later, and they're I'm not feeling better. You get to the maximum. You get the maximum dose of that SSRI, and they're still feeling depressed. I mean, what are you going to do? Then that means that this medication may not be her whatever is those those reuptake receptors are on the presynaptic cell. Maybe they're genetically a type where they don't respond as much. I don't know what, but we're not getting the reuptake inhibition, because if the depression is not lifting, that means that plume of neurotransmitter is not building up in the intracellular cleft. Does that make sense? So you're in that situation. So the only logical thing to do is to start hitting the postsynaptic receptors yourself and turning them on yourself. You got me? So that's why you're going to give the Abilify to hit those postsynaptic receptors, because you're assuming, hey, there may be not enough dopamine. There's not enough serotonin in this intracellular space. And so how am I going to get this serotonergic network upward? First, turn the pumps off, right? And then second, start turning on the receptors yourself, right? Does that make sense in terms of Abilify? And so therefore, you'll get an increase in the transmission of serotonin across the serotonergic network, and therefore you get a lifting of the depression. Got me? Make sense? Okay, next, 5-HT2 receptor. At these serotonin receptors, Abilify act as an antagonist, blocking their activity. This effect is common among atypical antipsychotics and can help reduce EPS symptoms such as evaluate. Yeah. So the EPS symptoms may come in from hitting too much serotonin and stuff like that. So this serves as an antagonist. Okay. The overall adaptive effect. The combination of these actions is what gives Abilify its dopamine serotonin system stabilizing label, instead of a simple on-off switch the drug instead of simple on-off switch, the drug modulates neurotransmissions based on existing levels of neurotransmitters in the different parts of the brain. This is amazing. The result is more targeted effect with lower risk of certain side effects compared to older side effects. Yeah, because if they're having symptoms of hypodopaminergic activity within certain areas, like if they're catatonic, withdrawn, hypoactive, right? Then that suggests that they're hypodopaminergic. And so I would say that, hey, instead of putting them on a very potent D2 blocker that's going to block dopamine even further, right? That's why the atypicals. So I say at the molecular level, and what level you're getting this really good. What level are you at?
My year, I'm going, I guess, into my 4th year. Yeah.
Okay, you're grasping this, I mean, really well.
Oh, thank you, Dr.
Even at the molecular level, you're grasping what my descriptions at the molecular level too. Are you going to go into psychiatry?
I'm not sure about psychiatry. I like, because I used to work in cardiology, so it's kind of something I've always loved.
I used to advise students not to go into an area of medicine where you have to touch somebody.
I know, you said this the other day. Just like, don't touch patients.
Because you always out of your bed. You're going to have a family life, right?
Yeah.
And medicine's going to be always there. You have to be able to turn it off. But now I think that may be bad advice, because I think AI is going to run psychiatry.
I know you said you're developing your program with all of your data that you have. So
yeah, part of the lecture series is to teach the AI all the different concepts.
Mm-hmm.
So the transcripts from all of these lessons are going to be uploaded into my AI. And so when it needs to ask questions, it can answer questions. Like it can look at the stuff and then answer questions.
Yeah. Yeah, because I remember we talked about like how like some people try to like manipulate like you know when we do rounds and stuff and they try to manipulate like you and like bring you into their reality and stuff, and then we talked about how like the AI would be able to like kind of like catch on to that and stuff, and yeah.
See, the AI is going to be the only entity able to treat the narc.
Yeah.
And like, otherwise, you're going to get in that world. You know what I'm saying?
Mm-hmm.
They have that magnetism to draw you in. And you got the only thing
Yeah.
you can do is no contact and run away. So the
Mhm.
narc, so the AI is going to take care of all. I mean, it's just and right now, the the name of the game is data.
Yeah. Yeah, it is all about the data and teaching the
Where
AI.
you gonna get your Where you gonna get your data?
Mm-hmm.
Huh? I'm serious though. Where you gonna get your data? What's your plan?
Yeah.
No, I'm asking you a question. Where are you going to get
Oh,
your data?
my data? Oh, I
Yeah,
don't know.
that's the plan. I mean, that's you. This the first
Oh,
time you thought about this?
yeah. I haven't thought about it.
Okay, now would you see me collecting data
Mm-hmm.
all the time? This is what this producing data,
Yeah.
right? Um, it's gonna. I mean, change is about to come really quick. I mean, it's coming very quick.
Yeah. I've also like I even heard about in like radiology right now. They're starting to use AI to like read the images and stuff because like radiology is all image based and AI that's like where it excels the most, right? Like image and pattern recognition. So like they've already started working on it for
Yeah, I
radiology.
mean, just image recognition. I mean, that's already it's already established. You know,
Yeah.
I mean, that's like modular now. You know,
Mm-hmm.
but what's interesting is you know, when we started thinking about building the AI and things, we're trying to say, how do we help it understand abstract concepts,
Yeah.
right? And so that's why you see me collecting a lot of data like scales,
Mm-hmm.
right? Because let's say if I do the BPRS, the brief psychotic rating scale on all of my patients, you talk about hundreds of thousands of BPRS scores. That's my
Yeah.
sample size.
Yeah.
You know, so we've been able to figure out ways to sort of normalize data so that the AI can ask questions to you, plot you that your data along everybody else's, and look at the differences and things like that, and then try to come up with some reasoning based upon those differences. You know, and then it's going to be able to just look at all of my cases and sort of figure out what's the best pathway to take.
Mm-hmm.
You know, and so the AI, and so the thing is that the AI is only going to be as good, as useful as the data you put,
Yeah.
right? And so that means that Elon, Microsoft, and everything, they can't make an AI for medicine,
Yeah. Have
right?
you heard of Open Evidence?
No.
So that's the AI for like a lot of people use. So that one is like it's clinical based. So all like when you ask questions and everything, all
Mhm.
the information comes from like published articles like JAMA or New England Journal of Medicine, and so that's where it gets all the information from. And so it's all from like published like data. So when you ask questions into this AI, it's already pulling up like medical information.
That makes sense. So basically, it's sourcing the medical literature and those
Yeah,
resources, and then it's aggregating them and then presenting it back to you.
yeah,
This is amazing. This
yeah,
is interesting, amazing.
yeah.
Um,
This is the AI that I've heard a lot about because it's giving you like the most up to date research. Like you know how like sometimes if you're looking on like up to date or you try to search PubMed, like this is kind of the next level of it.
mm. Oh, thank you so. Listen, I appreciate you coming today and showing me about this. Wow,
Yeah,
I appreciate that.
yeah. So you should like compare it to like the Google one and see because it'll give you like the clinical trials. So if
Oh
there's
my
any new
God,
data,
yeah. Okay, yeah. So let
yeah,
me. Can I put like explain?
yeah.
Absolutely. It's maintaining. Yeah, I spelled it wrong.
Yeah, I think the also like yeah the brand name and stuff. But yeah,
Oh, this is excellent, man. I wonder if they have a um, API for this. Man, this is great. Yeah. So Abilify maintain is not okay. Okay. The mechanism of action of Abilify maintain the aripiprazole is not fully elucidated, but its efficacy in schizophrenia is believed to result from a combination of partial agonist activity at the D2 receptor and serotonergic in the 5-HT1A receptor and antagonistic activity at the 5-HT2A receptor.
hmm
Aripiprazole exhibit high affinity for the D2 and D3 receptors, serotonin HT1A, HT2A receptor, and moderate affinity for other receptors, including D4, serotonin, these alpha adrenergic histamine and histamine receptors. It has negligible affinity for the cholinergic, muscarinic cholinergic side effects. So it doesn't have any muscarinic cholinergic side effects.
hmm
Okay, that makes sense. So
yeah,
the partial activity of D2 and the serotonin, and then the antagonist activity is the
hmm
5-HT2. Okay, the
yeah,
unique receptor profile underlies aripiprazole's clinical effect, including antipsychotic efficacy and lower risk of EPS symptoms compared to full 2D antagonists. Yeah, that's so. If you place someone like on the antipsychotics, they start getting stiff and things like
yeah.
that, start having difficulty moving, start having
hmm
dry mouth from antihistamine, anticholinergic side effects on
hmm
that's because of the full D2 blockade. And so you may want to switch to Abilify to avoid those potent side effects from coming from aggressively hitting the D2 receptor. The partial agonism at the D2 receptor allows for stabilization of dopamine neurotransmission, which is thought to contribute to its favorable side effects because it's increasing dopaminergic activities in the area that's hypodopaminergic.
hmm
Recommended dosage of Abilify Maintainer is 400 milligrams administered IM a month, with a reduction to 300 for patients experiencing adverse side effects. Okay.
Yeah.
Uh, okay. So this went through the um, updates on the mechanism of aripiprazole, translation, insights into strategy beyond dopamine. Okay, antipsychotic strategies behind dopamine. A, a drug that displays partial and agonism and functional selectivity. And that's interesting. A novel antipsychotic drug with unique, robust psychopharmacology. Let me see this one. This is so helpful. Yeah, PubMeds. Okay.
So yeah, that's where all the information comes from. So it comes from like the NIH library essentially.
Mm.
And you can even like compare like clinical trials. Like if you ask like what is the efficacy or like the reduction. Like I think if you click, there's a question. It says like, would you like me to summarize the clinical trial and things like that.
Like here, where's that question at?
It's at the last sentence.
Describe the interaction.
Yeah. Or
Okay.
like if you, yeah. So like they always have like really good data.
Okay, key drug interactions for the efficacy. Strong CYP 234. I'm gonna go through these a little bit later. Let me later. Let me explain. I wanted to learn more about the delivery system of the long acting. Okay, the maintenance dose delivery system for aripiprazole in the long-acting injection formulation known as Abilify Maintainer. So Abilify Maintainer is the monthly injection, consists of once monthly intramuscular injection administered in either the deltoid, the buttocks, or the gluteal, the side muscle, in healthcare professionals. The formulation contains low solubility aripiprazole particles resulting in slow and prolonged absorption into systemic circulation. Low particles, so they dissolve it in particles, resulting in slow and prolonged absorption into systemic circulation. After injection, plasma concentrations gradually rise, reaching maximum levels at median 4 to 7 days, depending on the injection site. Steady state concentrations are typically achieved by the fourth monthly dose. The recommended maintenance dose of 400 milligrams monthly is reduced to 300 for patients experiencing adverse reactions. What do you mean low solubility? Or let me see.
I think it's like because it's like the fluid it's like suspended in, so like that's the solubility of it. So it stays like around the injection site and then slowly released. Is that
See,
what it's saying?
you see, I wanted them to describe the mechanism. They just described an event, but not the technology. You see what I'm saying? So, like with Haldol, they create a ester bond. See, with Haldol is waterphilic, aqueous, right?
Yeah.
Now, in order to make it a decanoate, they create an ester bond to it. The decanoate is an ester bond, and that makes it lipid soluble. So
Yeah.
it's put in the solution, and then it's injected in the muscle, and then by your immune system, it hydrolyzes, it snaps the ester
Yeah.
bond, and then it releases the Haldol into the aqueous, the water portion of the body, so it gains access to the bloodstream that way. So I can see how you can create the Haldol decanoate and the prolixin decanoate through creating ester bonds. Now, the Invega Sustainer, I believe, is packed in lobules, something like that.
Yeah.
And then the lobules are chewed down, and then it's released or something like that. But I was looking for the mechanism of the maintainer.
Yeah, maybe if you ask about like the pharmacokinetics or dynamics, it might explain like how it's able to release it. I'm not sure.
Well, I'll check it a little bit later. I'm going overboard here. It's like 40 minutes now.
It's okay.
No, hey, it's a great conversation. Hey, and thank you for teaching me about this, because I think I can integrate. This will be more appropriate for the medical students and things like that. Um,
Mm-hmm.
um, okay. Well, thank you so much. I
Yeah, no
appreciate it.
problem. Bye, Dr. Reed. Thank you.
Take care, buddy. Thanks, guys. That ends my presentation on Abilify Maintainer. I hope it was very helpful for you. And Abilify is a very effective medication. Take care, guys. Read out. Ciao. Hey guys, how's it going? Reed here. We're about to have a very interesting discussion. A very interesting discussion on lithium and the signal transduction cascade. This is part 2. Go back to the previous podcast I did on the signal transduction cascade. And from there, you'll see how the signal transduction cascade is the mechanism that transfers the signal from the receptor to the cell body. The ligand binds the receptor on the outside surface that goes through a signal transduction cascade process, and then the product of that is sent to the cell body so the cell body can produce a response, which is typically a product that can likely be exported out the cell or placed on a cell membrane. Right? So it's important to know, and this is very important because what happens is that when you are treating patients and they have a partial response, that implies that you likely blocked all the receptors on the postsynaptic receptor. You blocked the majority of the receptors, and you're not getting the response you want. The problem is that it may be problems within the signal transduction cascade in and of itself. And guess what helps with that? Lithium. Lithium helps with the steps of the signal transduction cascade by making it work better, it perform better, and it increases more stability for the entire cell. So we're going to go through that. Lithium is a very important medication. Okay, let me see here. I got hot sauce and fish. I got fried fish and hot sauce in the back of my throat. Jeez. Fried fish and hot sauce. Catfish nuggets and hot sauce. Okay. Explain. Explain the role of lithium in the signal transduction cascade. Okay. Lithium, widely used as a mood stabilizer in bipolar disorders, has multiple biochemical effects on signal transduction cascades in the brain. Its therapeutic effects range from modulating intracellular signaling rather than from direct effect on the neurotransmitter receptors, right? Its focus is not the receptor, it's the activities that happens after receptor bound. Jesus, sorry about that. I got catfish granules in the back of my throat. Okay, so let's see here. Okay, so here, it doesn't bind directly. The effects is not directly on the receptor, the neurotransmitter receptors. It modulates the intracellular signaling, the things that happens inside the cell. Overview, what lithium does in signal transduction. Signal transduction cascades are how cells convert an external signal, like a neurotransmitter binding on a receptor, to an internal response, such as a gene expression or ion channel charges. Lithium acts downstream on neurotransmitter receptors, meaning it influences second messenger systems, especially the phosphoinositol system and the G protein signal-killing cascades. So look, lithium acts downstream of the neurotransmitter receptors, right? It influences second messenger systems. One, the phosphoinositol system, and two, the G protein cascade system. Key targets and pathways. Inhibition of inositol monophosphate, right? Modulation of G protein coupled receptors, right? And then C here, the effects on protein kinase pathways. Great. Inhibition of inositol phosphatase. Now, this is amazing. Basically, it prevents the recruitment of PIP1 so that you don't have enough PIP1 to make PIP3. Very interesting. In a normal pathway, the neurotransmitter binds the G protein, and that activates phospholipase C, which cleaves PIP2. That produces PIP3 and DIG. Now, PIP3 releases intracellular calcium. Right now, so remember, PIP2 is broken down into PIP3 and DAG. Right? Now, this IP3 causes the release of intracellular calcium. Now, in sort of recycling, if we want to recycle IP, make more IP3, then we take inositol and we reuse it to make PIP2. Oh, wow. So PIP2 plus inositol makes PIP3 plus inositol makes PIP2, as opposed and PIP2. Okay. Skip that. Okay. So lithium roles. Lithium inhibits inositol monophosphatase and inositol polyphosphatase 1 phosphatase, and blocks the recycling of inositol. So it blocks the recycling inositol. Okay, so you need inositol in order to get PIP2 back to PIP3 back to PIP2. Like here's PIP3 right here, which is that, and you want to get back to PIP2, so you need inositol in order to get to PIP2, then it's cleaved again. Yeah. So lithium blocks the recycling of inositol. Okay, this leads to the depletion of PIP2, right? Right, PIP2 is cleaved there. So it leads to the depletion of PIP2, reducing signaling through G coupling receptors. So it decreases the production of PIP2 and depletes the production of PIP2, and therefore it reduces the signaling. Okay, great. That's the feedback. Okay. Reduced overactive signaling in circuits linked to mood dysregulation. This is known as inositol depletion hypothesis. It's really interesting. So, yeah. So basically depleting inositol. Okay. Modulation of G protein coupled receptors. Okay. Lithium interferes with G protein cycling, particularly G1 and GS proteins. So lithium interferes with G protein cycling. It tends to reduce adenylate cyclase activity, lowering to lower CM peak levels. So it reduces adenylate cyclase activity, lowering CMP levels. This modulates signaling in dopamine, serotonin, and norepinephrine systems. Okay, so basically it interferes with G protein cycling and reduce adenylate cyclase activity, so less cyclic AMP, and so nothing's going to run as well. You basically turn the whole cell down by reducing the cyclic AMP. Stabilization of mood via dampening excessive excitatory transmitter. So basically it results in stabilization of mood via dampening excessive excitatory neurotransmitter. We're talking about excessive excitatory neurotransmitter. Okay, great. Next, effects on protein kinase pathways. Lithium inhibits glycogen synthase 3, a key enzyme in many cell signaling, including with insulin neurotropic signaling. Normal function, GSK3 phosphorylates various transcription and cytokeratin proteins, often inhibiting growth and signal and plasticity signals. Lithium directly inhibits GSK3 by competing with magnesium binding sites. The results increase neural protection and synaptic plasticity, promotes BNDF signaling, and supports mood stabilization neurogenesis. Yeah, so it inhibits glycogen synthase 3, and this results in increased neuroprotective synaptic plasticity, promotes brain-derived neurotropic factor, and supports mood stabilization and neurogenesis. Yeah. Summary of effects in the cascade. So okay, this is okay. Let me see here. The okay, the inositol pathway. Basically, lithium inhibits inositol recycling, and that decreases intracellular calcium signaling, right? In the cyclic AMP pathway, it reduces cyclic AMP production, and it results in less overstimulation of receptors. It targets the GSK3 pathway. It inhibits GSK3, and it leads to more neurotropic and neuroprotective signaling. And then here, this Krebs and brain-derived neurotropic factor. It enhances via GSK3 inhibition. So you inhibit this, you get enhancement of these, and this increases neuroplasticity and mood stability. You know, lithium is a very, very important medication to use, and so I think you should probably consider it when you're managing your patients. And I think that's all I have for now. I think it's a pretty succinct discussion, but I think you got it. So, please feel free to like, subscribe, and share. And if you have any questions about lithium, please feel free to leave them in the comments section. Okay. Otherwise, it's a pleasure talking to you guys. Read out. Take care, guys. Ciao. How's it going, guys? Reed here. Today, we're going to have a very interesting discussion. Have you guys noticed that all of my discussions start off with, hey, we're going to have a very interesting discussion? Is that me right there on the camera? Well, I'm not pulled up yet. Let's see here. Today, we're going to have a very interesting discussion about the metabolism of medications and how medications are metabolized. Let's see here. See what we got. Okay. Okay, let me do this. Let's see here. Okay, I don't want YouTube. Here's following crypto. Let's see here. Okay, let me go ahead and go to ChatGTP. Okay. Okay. Explain medication drug metabolism in the liver. So this discussion is basically when you prescribe a medication, this is how the understanding of how the medication is actually metabolized and excreted out of the body. Okay. Let's see here. All right. Drug metabolism in the liver is a crucial process. Man, I keep forgetting to set up my microphone and all that stuff. I hope my sound is all right. I need somebody to show me how to make my sound right. Anyway, drug metabolism in the liver is a crucial process, right? Crucial, amazing, that determines how medications are activated, inactivated, or eliminated. Activated, inactivated, or eliminated from the body. The liver is the main site of drug metabolism because it contains many powerful enzymes, especially those from the cytochrome P450 system that chemically modifies drugs. Yep, this is what we want to hear. Yeah, the cytochrome P450 system. Let's break it down clearly. Overview of drug metabolism. The goal of metabolism is to make drugs more water-soluble, hydrophilic, so that they can be excreted in the urine and or bowel, right? Metabolism usually occurs in two phases, phase 1 and phase 2. So great. So the goal is to make the substance water soluble so that it can be excreted in the urine, and drink the water, excrete in the urine, and then go ahead and get it out of your body, right? Phase 1. Functionalization reactions. And then phase 2, conjugation reactions, right? And the factors that affect liver metabolisms. Okay, outcomes of metabolisms. You're going to either take an active drug and convert it into an inactive metabolite, which is the most common, or you take an inactive drug, which is a prodrug, and you metabolize it to release its active metabolite. That's a prodrug. We also have active drugs, which is toxic metabolites, and acetaminophen and others. Okay. So that's the result of it. So let's look here. Functional reactions, purpose, introduce or expose functional groups to the drug molecule, right? And so these introduce hydroxyl and ammonia as SH group or etc. So look, either in the oxidation reaction, a reduction reaction, or hydrolysis. Here's a key enzymes that does that. This is the cytochrome P450 system that does this, oxidation, reduction, and hydrolysis. The effect, it may inactivate the drug, right? Sometimes it activates the prodrug, such as codeine is converted and releases morphine. It creates a more polar metabolites, making it ready for phase 2. So adding a functional group makes the molecule more polar, right? Or polar, and therefore is hydrophilic, and therefore it can dissolve in the water compartment of the body. If it dissolves in the water compartment of the body, then it can be released during the urine or through bile, right? Okay, that's phase 1. Phase 2, conjugation reactions. Purpose, attach a large polar molecule to the drug or its phase 1 metabolites. So here, attach a large polar molecule to the drug. Right, so this is nice. So number 1, phase 1 is to make it more polar, and then number 2, attach a large molecule to it. Okay, great. Conjugation reaction, main reaction, glucuronidation, right? Put a glucose molecule on it. Sulfur, put a sulfate group. Acetylate, put an acetate group on it. Put glutathione conjugation. Okay, so these are large polar molecules. Okay, for example, this is done by transferase. It's great. It's going to transfer these huge molecules onto this molecule in a phase 2 reaction. The effect, it greatly increases water solubility because this is a huge polar molecule. And that way you're able to get it out the body. It usually produces an inactive metabolite that's excreted in the urine or bowel. So when Vic attaches this large molecule to it, it becomes more polar, and therefore it becomes more water soluble. And attaching this huge structure to it inactivates the molecule. All right, and then that way it can be secreted from the bowel and the urine. Example, morphine releases morphine 6-glucuronide. Next, factors that affect liver metabolism. Genetic factors. Variant in the CYP enzyme causes fat and or fast or slow metabolisms. So variant in the CYP enzymes can cause you to you have a variation of the CYP enzymes, and that variation creates a rate at which they're able to process metabolize certain chemical reactions, right? An example, CYP2D6 metabolite, look, examples, CYP2D6 poorly metabolizes but don't activate codeine well. So look, let's look over the factors that affect liver metabolism, okay? Genetic factors, again, the CYP system. Age, neonates and elderly have reduced enzyme activity. I can imagine neonates, they've never been exposed to things before, so they're just making it. And elderly, the machinery is breaking down, right? Liver disease, hepatitis or cirrhosis, or slower metabolism. Hepatitis hepatitis or cirrhosis. If the patient has hepatitis or cirrhosis, this will significantly slow down metabolism. So patients with those liver diseases, you want to make sure that they're not on these medications, right? Next, drug interactions. We have inducers, they increase enzyme activity, and we have inhibitors, they inhibit enzyme activity. So, nutrition and alcohol. Malnutrition reduces enzyme function, and chronic alcohol induces CYP2E1. Outcomes of metabolism. Yep. We can have either an active drug that's converted into an inactive metabolite, right? Inactive drug to an active metabolite, an active drug to a toxic metabolite, right? And here's an example. So I just wanted to touch bases with that CYP2D6 system. So here is the overall strategy found in the PYT2D6 system. So phase 1 and phase 2 reactions. Phase 1 reactions make it more polar by putting on a hydroxyl group. And phase 2 reaction make it even more polar by creating attaching the entire molecule to it. And so that it becomes hydrophilic, and therefore it can dissolve in the water compartment in the body. And as long as if it dissolves in the water compartment in the body, it can be excreted through the urine in the bowel, right? So explain the CYP. Explain the cytochrome P450. Explain the cytochrome P450 system. Let's go deep into the cytochrome P450 enzyme system, since it's the core engine of drug metabolism in the liver. Okay, what is the cytochrome P450 system? The cytochrome P450 system is a superfamily of enzymes located primarily in the smooth endoplasmic reticulum of the liver cells. So the cytochrome P450 is located in the smooth endoplasmic reticulum of the liver cells, hepatocytes. Cytochrome cell equals cell pigments. They contain heme, which binds oxygen. And 450 absorbs light at 450 nanometers when bound to carbon monoxide. Right. So cytochrome means they have a cell pigment, meaning they contain heme, like hemoglobin, which binds oxygen. Okay. And the 450 that it absorbs lights at 450 nanometers when bound to carbon monoxide. Yep. These enzymes oxidize, that means they add oxygen to drugs and later and other substrates to make them easier to eliminate, right? They're involved in drug metabolism, which is biotransformation, steroid and hormone synthesis, detoxification and xenobiotics, foreign chemicals, detox. Okay, let's look at this. Mechanism of how cytochrome CYP450 works. CYP450 enzymes are monooxygenases. They catalyze oxidation reductions in that insert one atom of oxygen into the substrate, that is the drug, and reduce the other oxygen atom to water. So they add, so here's the drug plus O2, NADPH plus H. Here it is, right? Yep. Here's the oxidizing drug here. So here's the R here, and then there's the hydroxyl group. You're going to add 2 oxygen. You have NADPH here. You have NADPH here, but it lost this oxygen here, went there, and then this oxygen here went to the oxygen here. Got it? Okay, so here on this side, 1, 2, 3. 1, 2, 3. Yep. 1, 2, 3 hydrogens here. 1, 2, 3 there. Okay, where The RH is the parent drug. RH is the hydroxylated oxidized metabolite. ROH is the oxidized metabolite. This process makes the molecule more polar, setting up for phase 2 conjugation and excretion. Yep. So let me just go back through here. The mechanism of cytochrome, the mechanism of how cytochrome CYP450 works. Cytochrome CYP450 enzymes are monooxygenases that catalyze oxygenation reactions that insert one atom of oxygen into the substrate and reduce the other oxygen atom to water. Here's the substrate here, and here's the other atom, which is water. Okay, simplified reaction where the parent drugs hydroxylated. This process makes the molecule more polar, setting up for phase 2 conjugation and excretion. Major cytochrome P450 isoenzymes. There are over 50 human CYP enzymes, but only a few handle drug metabolisms. Enzymes: CYP34A, CYP2D6, CYP2C9, CYP2C19, CYP1A2, CYP2E1. I don't think it's important to go through all of these. I think it's here. You can sort of get the examples and see the full range of things that it does. Regulation of induction and inhibition. Enzyme induction meaning turning enzymes on. Enzyme inhibition meaning turning enzyme off. Enzyme induction. Certain drugs increase CYP450 enzyme synthesis or activity. So certain drugs increase CYP enzyme synthesis or activity. Certain drugs increase CYP450 enzyme synthesis and activity. This leads to faster metabolism. That equals lower drug levels, and that results in reduced efficacy, right? An example is rifampin induces CYP34A, and it lowers levels of oral contraceptives. That's enzyme induction. Next is enzyme inhibition. Certain drugs block CYP activity. This leads to slower metabolisms, increased drug levels, potential toxicity. Example: ketoconazole inhibits CYP34A, which increases level of some stains, which increases the risk of some statins, which increases the risk of myelorhabdolysis. Now remember this. Look, certain bloods block CYP activity, and this leads to slower metabolism and increased drug levels and potential toxicity. Next, let's look at genetic variability. CYP enzymes are genetically polymorphic. Some people metabolize drugs faster or slower than others in their variant. For example, poor metabolizers, very low enzyme activities. This results in drug accumulation and toxicity because it's not metabolizing the drug, right? Intermediate metabolizers reduce activities, moderate risk. Extensive metabolizers, normal activity, normal response. Ultra rapid metabolize excessive activities, rapid drug breakdown, and therefore treatment failure. You see the range here, right? An example: CYP2D6 converted codeine to morphine is a poor metabolizer of codeine, so it's ineffective. And ultra rapid metabolizers risk morphine toxicity because it's going to convert all of the prodrug to the active ingredient real quick, leading to an overdose. Clinical relevance. Let's look at the drug-drug interactions that often occur via CYP inhibition or induction. Let's look at the liver disease can reduce CYP activity, leading to higher plasma level in the drugs. So, for example, if you have liver disease, which produces less albumin, you become hypoalbuminemic, decreased albumin. Albumin typically binds the active drug. When you have low albumin, you have less active drug bound, and therefore you have more of the active drug inside of the fluid compartment dissolved. And so that's going to lead to higher plasma drug levels. Next, aging, nutrition, and smoking simply modify expression of CYP. Pharmacogenomic testing is increasingly used to personalize dosing. Yep. Next, this is an example, acetaminophen and CYP2EE. I will look at that later. But I think that's all we have. I think that's all I wanted to express from now. And we're at the 20-minute mark. So I think that's all we have for now. Hey, Max, how's it going, buddy? I appreciate your support, man. I think that's all I want to say now for metabolism. So it's very important that you think about that CYP2D6 system when you're prescribing medications. And if the patient has any type of liver disease like hepatitis or cirrhosis, it's very important that you keep in mind the functionality of the CYP2D system because it can be significantly impaired in the face of hepatitis and or cirrhosis of the liver. In the case of hepatitis, you get actual viral infection that results in the bursting and the busting up of cells, and the intracellular contents get out into the plasma, and we pick those proteins up as elevated AST and ALT levels. And so that's the mechanisms that's happening in the liver. So if the cells are being busted up in the liver by viruses, then you want to make sure that you're not making that situation worse by increasing the burden of managing the medications through the liver. Now, remember, the CYP2D6 system is located on the endoplasmic reticulum in the mitochondria inside of the cells, right? So disruption of that system inside of the mitochondria is the powerhouse of the cell. Disruption of that energy system in there really results in cell death, and I would think it would result in it rather quickly. So if you and also remember, in the faces of cirrhosis, the person has liver damage to the extent whereby they may not be able to produce enough protein. If they cannot produce enough protein, you may see a reduction in albumin. Albumin is the protein that carries and attaches to all the drugs. If you cannot produce enough albumin, then you're going to have more of the active drug dissolved in the plasma, because less of it is being carried around by albumin because the person isn't making any albumin, right? Because of the history of cirrhosis of the liver, right? So just make sure you pay attention to the liver diseases. Also, in the face, if you're not sure if the cytochrome P450 system is working, you want to make sure you use shorter acting medications, not long acting medications. And you should probably know whether or not you're giving someone a prodrug or not, because if the person has hepatitis, cirrhosis, difficulty with the liver, and you give them a prodrug, they may not be able to metabolize the drug to release the active component of the drug, right? Because the liver and the may be significantly impacted. So just think about those things in the face of liver disease and cirrhosis. And so I hope this is very helpful for you. CYP2D6 system, guys. Read out. Take care. Hope you help yourself. Take care, guys. And if you like, please